I welcome all of you to today's webinar series on strengthening primary healthcare by next year. By way of introduction, a robust healthcare system is essential for national development. Nevertheless, Nigeria's health sector grapples with numerous systemic challenges, such as fragmented services, inadequate funding mechanisms, disparity in access to care, and notably inefficiencies in governance and the implementation processes. In response, the federal government, through the Federal Ministry of Health, introduced the sector-wide approach as part of its Health Sector Renewal Investment Initiative. And this framework is designed to enhance primary healthcare services, establish financial protection mechanisms, and advance universal health coverage for the Nigerian populace. Even with these efforts, Nigeria is still at a critical juncture in its healthcare transformation, particularly in strengthening primary healthcare as a foundation for attaining universal health coverage. With a population of over 220 million and a multifaceted disease burden, there is an acute need to address the persistent gap in healthcare delivery, financing, human resources, and governance that disproportionately affect vulnerable populations. So Nigeria's primary healthcare system is faced with myriads of issues, notably low functional PHC facilities, severe shortage of skilled manpower, high out-of-pocket expenditure, poor quality and regulation of care, and low immunization coverage and uptake, not to talk of chronic non-communicable disease burdens that has plagued the country. Today's healthcare dialogue series will be discussing strengthening primary healthcare and expanding universal health coverage in Nigeria. I have two distinguished panelists here. I will introduce them one after another. Dr. Simeon Onyemachi is the Managing Director and Chief Executive Officer of the Anambra State Health Insurance Agency. He also doubles as the Chairman of the Forum of Executive Secretaries and Director Generals, Chief Executive Officers of the State Social Health Insurance Scheme in Nigeria. He's a public health expert with over a decade expertise in pioneering healthcare financing strategies within resource-constrained environment. Dr. Onyemachi has made significant strides in health policy reforms to enhance health outcomes. He spearheaded an innovative health insurance initiative, introducing what we know today as the adoption model, which is tailored for the informal economy in Anambra in Nigeria. This groundbreaking approach has served as a replicable framework across Nigeria, yielding similar access and health security improvements. Dr. Onyemachi also directed a team of tech-savvy professionals in developing Nigeria's first fully operational subnational mobile health insurance platform. This initiative has substantially increased health insurance accessibility and uptake for rural populations, bridging crucial gaps in healthcare coverage. His collaborative efforts extend to multinational, bilateral, and regional entities, including working with the World Health Organization, the USAID, the European Union, and the Center for Disease Control. Before this accomplishment, Dr. Onyemachi has served as the head of the Monitoring and Evaluation Department in the National Tuberculosis, Borreliosis, Ulcer, and Leprosy Control Program at the Federal Ministry of Health. He's a graduate of medicine from Madonna University, holds a master's degree in public health from the University of Roehampton, London, and a PhD in public health from the University of Central Nicaragua. The next panelist is the distinguished Dr. Usman Ibrahim Gebi, a dynamic infectious disease and health system strengthening leader with over 3 decades of expertise in high-level program management, strategic planning, and technical oversight in the health sector. He has a proven track record in implementing high-impact health initiatives, ranging from tuberculosis, malaria, HIV, especially over the last 7 years in health system strengthening, particularly the primary healthcare and service delivery level integrations in the MNHCH and MN HIV, malaria, and nutrition programs, focusing on service delivery improvements, stakeholder engagement, and sustainability. his experience in leading cross-functional teams to achieve substantial health service delivery metrics across multiple Nigerian states. Dr. Gaby is a graduate of medicine from the prestigious Ahmadu Bello University, Nigeria, a fellow of the National Postgraduate Medical College of Nigeria, certified in leadership strategies for evolving healthcare executives, Harvard Chan Public School, certified in advanced statistics and data management from the University of Maryland, also certified in medical research ethics and oversight, University of Maryland, and certified in strategic health communications, Bloomberg School of Public Health, Johns Hopkins. So distinguished ladies and gentlemen, you agree with me that we have some panelists, also a group of panelists that have got what it takes to discuss this thought-provoking topic, strengthening primary healthcare and expanding universal health coverage in Nigeria. So you're welcome, Dr. Simeon Onyemachi. You're welcome, Dr. Usman Gaby.
Thank you so much.
Thank you so much.
Okay, so I've given a brief introduction to the challenges that we have with primary healthcare in Nigeria. And suffice to say that we've always had challenges with budgetary allocations and releases when it comes to supporting the healthcare system. And part of the argument people have had is that 80% of the resources goes to tertiary centers where we have just 20% of people presenting. And then we also have 20% of resources going to the primary healthcare center where 80% of people present. And that has really presented a challenge. But with the coming of the sector-wide approach, which is the initiative, the Nigerian Health Sector Renewal Investment Initiative, we hope to see something that looks like a shift towards strengthening primary healthcare in Nigeria. So I'll start with you, Dr. Gaby. What are the principal obstacles to accessing primary healthcare services in Nigeria from your practical experience?
Well, thank you very much, Dr. John Chang, and people on the webinar. As far as all of us would recall, it's like, whereas we would say that we are in a particular stage in the journey towards universal health coverage in Nigeria, this journey actually had begun way, way, way beyond the current, what I call strategic shift in terms of the SWOP approach led by the current government. And in order for us to put this in the proper perspective, we need to kind of know where we're coming from. Yes, of course, some of the challenges along the primary healthcare access actually works both on the demand and the supply side of the health system. Now, from the demand side, you find that particularly from the primary healthcare centers in terms of governance and leadership, in terms of the structure, in terms of the skill sets, in terms of priorities, in terms of health finance, down to the respective service delivery areas and the monitoring and evaluation, there are different challenges that have kind of belabored progress in this particular aspect of the what I call the gateway to access to the healthcare system. As it is, if you recall, in terms of governance, prior to this, there's been a lot of fragmentation in terms of the governance of the primary healthcare system. Earlier on, it's like it's being managed as per the law under the local governments. And therefore, because of this fragmentation, because of this multiplicity of ownership, with the primary healthcare being under the local government, general hospitals being the state government, and some federal, and then the tertiary being at the federal level, you found a lot of what I call too many cooks. And as such, each one is cooking a different soup, a different kind of meal for a particular problem that needs a focused particular approach. And therefore, the key challenges that were there include issues of even the laws that kind of created these particular entry points towards the health system and called for fragmentation. And this fragmentation is the bane of the approach towards having a harmonized approach independent of the common problems that were there. So problems of policy. Secondly, there's also the issue of the fragmentation of policy, fragmentation of ownership, And with that ownership is also the complete disenchantment and non-involvement of the people that are supposed to be the users. You find that there's always been the top-bottom approach in terms of deciding what is important, what should we focus on, and it's like the complexity of the nation of Nigeria is such that you cannot have one size that fits all, and as such, for the same problem, you would need to involve the people so that you would see what are the challenges that they have and how can you tailor the need that you want to provide to fit their own sociocultural issues on any common disorder, particularly issues to do with the biggest causes of morbidity and mortality, particularly to do with reproductive health, maternal and child health, because mothers and children are the most common people that attend, particularly for very common ailments, and also childhood mortality and morbidity are some of the biggest causes of death in Nigeria. Again, the same fragmentation in terms of resources. Now, it's like predominantly primary healthcare has been funded in theory by the federal government initially, and then the state governments and the local governments. But it's like exactly, do they have a common budget platform to address specific issues that have been tailored to the needs that have been showed by the data that we generally have to guide some of the responses that are there? You find that it's like the very common demographic health surveys that take place that identify in a very specific way some of the common ailments and issues that we have that address some of the issues that causes morbidity and mortality. Is like you find the different levels of government decide on which areas they're going to focus. And then the budgets, even when available, is like you hear what I call these humongous multi-billion naira budgets that are there, that are kind of budgeted, that never get released. And even if when they get released, there are the many issues of skill sets, the centers themselves, the availability of logistics, and even geographical challenges. So these are the many challenges that have been listed. But again, the one approach that kind of centers about the same medication the same approach for all the ailments was found not to really cater for most of the needs that we have. And there are some key strategic issues that the government of Nigeria had taken that had allowed some centricity of some of these approaches. Now, the revised Health Act actually put most of these issues and decided to pull all these things together so that together with the swap approach, now we have, so that it's like all the stakeholders from the communities, the local government, the state would have and identify so that the nation, states, local government, and communities will have one plan, one budget, and one monitoring and evaluation mechanism so that across board, it's like when I say it is green from the top to bottom, and we're talking about the same thing. And then we can concentrate so that each area will, based on that one plan, decide on what are the best things that they can do that allows them to deal with the problem with that particular community, that will make sure there's sustainability. Secondly, there's also the significant dependence on what I call partners. Whereas it's like government makes an approach and says, this is the direction we're going to flow. Prior to the onset of the SWAP approach, you find that it's like you want to cook a soup, and then it's like many people come and tell you they want to help you to cook that particular soup. But I will decide that I'm bringing only the vegetables. But it's like we don't need vegetables at that particular point in time. But I'm bringing only vegetables for you, and you have to take it because I planned it myself, and I come that I want to help you, and I decide where you need this particular component. I will be the one that will decide as a partner with the resources that will come and decide where I want to go to. And as such, there's complete lack of coordination, and therefore it did not allow us to optimize particularly the functionality of these PHCs, and also the other levels of care, particularly in terms of referrals from primary healthcare to secondary healthcare. So you may find thousands of implementing partners working in various communities in a completely desynchronized mechanism so that you do not see the optimization of services, no matter how much resources that are given. And then most importantly, it's like when you're going to measure the inputs in terms of the outcomes that these people are supposed to support, each particular partner is coming with a different measuring mechanism. And as such, you cannot kind of compare apples to oranges. This one is measuring oranges, this one is measuring apples. And it's difficult for government as the custodian of the populace to kind of look at data and decide these are the issues that need to kind of so that we can see the contribution that all these people are making and how is it contributing to better health outcomes. That's the second option. And then lastly, you find also the issue of measurement, like I mentioned earlier. It's like, despite the fact that across the years, the government has done quite a lot in terms of trying to harmonize monitor and evaluation tools, you have found a lot of disjointed, what I call tools that are brought by partners, sometimes by government itself, modifications are made, and these are not kind of tailored down. And the people that are supposed to kind of enter some of this basic data are not necessarily trained enough to measure and enter what is supposed to be entered. And therefore, you find very, very kind of a lot of numbers that are entered that don't necessarily measure what is supposed to be measured because of poor skills at that particular primary healthcare center, because human resources has been the huge, there's been a huge kind of contribution in terms of its absence of appropriately trained healthcare workers for that cadre of health workers so that they'll be able to provide services as well as enter the appropriate numbers for the service that they're offering in the appropriate tools, and then use this to channel it up across the chain down to the federal level, and at the local level, be able to use some of those numbers to make decisions. So you find that people that are even entering the right thing are just being extremely mechanical in terms of pushing this upwards and are waiting for somebody else to direct them over what to do, amongst the many other things. I think maybe I would pause so that we can continue, and then we can address maybe if there are specific questions. Thank you.
Yeah, fantastic and beautiful insight into the principal obstacles of accessing quality primary healthcare services in Nigeria. Dr. Onyemaechi, you've been around for quite some time, and I would confidently say that you have transformed into an authority when it comes to providing financial risk protections for people, particularly vulnerable people. Sometimes back in 2014, the federal government of Nigeria, under the leadership of the then president of the Federal Republic, Goodluck Ebele Jonathan, passed the National Health Act, which eventually gave birth to the Basic Healthcare Provision Fund, where at least 1%, nothing less than 1% of the consolidated revenue fund of the federal government was shared amongst the 36 states and the FCT. So services can be provided for the vulnerable group. After the operationalization of the BHCPF for that period, there was a call, there was a deep dive to revitalize or to look at the Basic Healthcare Provision Fund. So in what ways will the revitalization of the Basic Healthcare Provision Fund enhance efficacy and reach primary healthcare services in Nigeria?
Yeah, thank you so much, and good day, everyone on the call. Just to say that we must underscore the point that more money does not always translate to more health. More money will only translate to more health when you have strategically thought through, from design phase through implementation to measurement of expected outcomes, as well as the right tools to be used to track those outcomes from design phase to implementation. If that does not happen, whatever you throw in will really not give you any much difference in terms of population health outcomes. Having underscored that point, you're about PHC the BHCPF revitalization, which is currently ongoing, especially within the context of the SWAP initiative, which the Honorable Coordinating Minister for Health is driving at this time in the Renewed Hope agenda of the federal government. There are critical issues that have had to be looked at in the past couple of months leading up to this time. We have looked at the governance structure, especially with regards to the current LGA autonomy that is going on, whereas in the past we had that because of the failure at the level of local government to effectively administer the primary health system, especially with regards public primary health centers, we needed to then as a country come up with a quick fix mechanism, like I would prefer to call it, which is what we did with having to say we cannot just let our baby die. Therefore, there was the creation of state primary health care development agencies, such that primary health care was now being run administratively and technically from the state government level. But then, with the advent of local government autonomy at this point, there now became a huge need for us to look at the governance structures at that level again, knowing that at every primary health care, at every local government level in this country, there are supervisors for health. But then the officers in charge of these various primary health centers who will implement the BHCPF had become used to taking administrative and technical instructions from the state primary health care development agencies. So there was a need to look again at BHCPF implementation, resulting in those revitalization documents that currently exist, where we looked at clearly how do we integrate the function of the supervisors for health at the various local governments and the local government chairman, who, in line with the National Health Act, are supposed to act as the chairman of the local government health authorities. How do we have a fusion that will not result in power tussles and then we have a lot of fragmentation? So that policy document, which the BHCPF revitalization, which we commonly call BHCPF 2.0, has looked at to say, how can those two parties now work together? So there is a streamlining of the oversighting at that level, integrating properly the actors at the local government and those at the primary healthcare development agencies across the states. So we equally had that as part of lessons learned, that over the years, we have had quite a lot of inefficiencies, even though it was thought true to say, when we want to implement, let us do direct facility financing. These monies are released in line with the National Health Act 2014 to say, send this money to the various subnational levels, and then instantly they are disbursed into specific primary health center commercial bank accounts to implement certain work plans that had been approved in the past, that will see improvements in infrastructure at the PHCs, that will see optimization of human resource for health, as well as to make available the essential medicines, consumables, and whatever it is they need to deliver this care, so that ultimately service delivery is improved at that level, to begin to have that tectonic shift, if you may say, from most of our patients going to secondary and tertiary facilities to building confidence at the primary healthcare level. So at this point in this revitalization, we have tried to look at why are people going to secondary facilities? As country policy, we have that you must see specialists for you to treat conditions like non-communicable diseases. Someone has got hypertension, you have to go to a general hospital, at least in the list. Someone has got diabetes mellitus, you must go to a general hospital. So some of these policy creations have resulted in the skewed nature of patient flow as we know it today. So in the BHCPF 2.0, which is the revitalization, there has been a conscious effort to say, you know what, we must do task shifting. As a matter of fact, the country already has got task shifting and tax policy framework to say, stable patients who have non-communicable diseases, can we begin to attend to them at primary healthcare levels? If I just need to refill antihypertensives and oral hypoglycemics, for instance, can I be attended to at that level? When we begin to do that, it will equally give us another policy challenge, which will be the capacity at that level. So in line with the SWOP, which is trying to say one plan, one budget, one M&E, there has been these 120,000 healthcare providers at the various, healthcare workers, I beg your pardon, at the various PHCs in all the 774 local government areas of Nigeria, the capacity building that has gone on to expand their knowledge base, to equally prepare them to be able to take on more tasks that will be shifted to them in line with this PHC revitalization. There is also in this revitalization an attempt to bring together what is happening in all of the 4 gateways of BHCPF to say, rather than us operating in silos, these reproductive maternal and child health cases that need referral, how do we get them in an integrated manner to get to the secondary facilities when they need those services? So there is the RESMAT program, Rural Emergency Maternal Transport Scheme, to which the National Emergency System and Ambulance Services will be operating to have these tricycle ambulances to commute rural maternal and child health cases to where they will get the needed services. So on paper, this design is looking very good. But then if we do not take very careful steps in ensuring that people are held to account at that level, it will be a beautiful policy like we have always had in this country. So there was now an infusion of the PFMO concept, that is the Project Finance Monitoring Officers, because the accountability framework that was initially built into the design of BHCPF was to say, let us get the World Health Development Committee members to be the chairpersons and then oversight the expenditure and utilization of funds at that level, such that before you make any procurement or purchase whatever, you must get a concurrence from the community themselves, who are the hosts and beneficiaries of these monies. But over time, we found that there have been collusions between some of these WDC chairmen and the officers in charge, such that these monies that were meant to provide these needed services have been just frittered away. So there is a new concept to say, let us get independent observers who will then oversight these expenditures. Yes, it is putting a lot more on in terms of oversighting the funds that will go into oversighting this fund. But then if the PFMOs hypothetically now work very well, then we will have that there is somebody guarding the guard, because the common saying, who will guard the guard? So now we have somebody to police the police. So the PFMOs, the Project Finance Monitoring Officers for the 774 local governments will then go in to make sure that we begin to track the expenditure at that level, such that this increased funding that the revitalization is going to channel, let it not go the way of things that had happened in the past. So I think there will be more accountability from both the demand and supply side going forward if we do it at this model. Thank you.
Fantastic, Simeon. Speaking from a very pragmatic approach. Dr. Gebi, you have served as both Deputy Chief of Party and at the same time Acting Chief of Party of the USAID IHP project here in Nigeria. And you also participated in training the workforce that Simeon Onyemachi mentioned. So can you briefly, in a minute or so, throw more light on the human resources of health training? He mentioned 120,000 numbers.
Yeah, thank you very much. And thank you, Onyemachi, for the very elaborate policy review. Now, one of the things from a practical example, because basically over the last almost like 6 to 7 years, we had in a way modeled what I call a micro swap, so to say, in 4 states. And some of the lessons that we have learned have helped to kind of improve some of the activities that have been designed in the swap. Now, one of the key missing links is particularly the skill sets that particularly at the primary healthcare level that the leadership has to have in order to make sure that they're implementing what is on the plan in line with the strategy, in line with the skill sets for which they've been given, and in terms of monitoring and evaluation. And for this, working very closely with the Primary Healthcare Development Agency and other partners. It was developed a kind of what I call a primary healthcare management skill set that kind of has now been able to train these people in terms of how to utilize the multiple funding flows that are coming into the primary healthcare directly. Remember, from the Basic Healthcare Provision Fund, from both the supply and the demand side, there are funds that are coming in. Also from the local government facility and local government financing under the primary healthcare under one roof that is being managed at the state level by the state primary healthcare agency. Some of the donations that they have from the communities, from the community network that they have developed as part of the primary healthcare approach, and the many other inputs that they are receiving so that they can all develop and map these things on the resources and be able to use this in an integrated and a cohesive manner, and there's no wastage, and all these things are accounted for in a tool that kind of moves upstream and also comes downstream to make sure that some of the managers that the doc talked about would be able to monitor pretty closely to make sure that these things are done very well and to make sure that all those things are retired before you can have a replenishment of some of these funds. Now, some of the big issues that have come in is like, and this varies depending on where you're coming from. And one of the advantages of SWAP is like, unlike what we did before, which was limited to some states, in the SWAP mechanism, there's no orphan states. All the states and all the 774 local governments are all involved, and people have been identified and have been made to have those skills and also to work down those skills beyond just one person. So that when we tried, and the government is trying to make sure that we are strengthening systems and not strengthening individuals. There are a lot of challenges because remember, again, you train people and people move, get promoted, some get retired, and so on. And so these things need to be continuous and make sure that it is continued so that you have sustainability of systems rather than individuals. And it is important, some of the mechanisms that the SWAP mechanism has put includes these quarterly meetings and also biannual meetings where you have all the stakeholders, government, representatives of the communities, donors, and all other stakeholders that come together and review these numbers on those shared framework that all have agreed upon so that they see where are they kind of doing well, where are they not doing well, do they need to kind of refocus on where they are not doing well. Now, some of the things that have come up from some of the quarterly meetings that have happened on the various zones include the issue that sometimes there's always the issue of flow of funds. Sometimes funds get delayed. Some of the budgeted things don't come when they are needed. Some of the people that have pledged some resources don't meet them on time. And then the biggest challenge that has come almost like at the beginning of the implementation, if you'd recall, some of the partners, I don't want to go into names, but well, I think maybe it's better to just say them. Particularly the United States government has been a key partner in the development as a partner in this big plan that we have had and had earlier on pledged resources so that other partners can kind of concentrate on some of the other things that they are going to do, and government would also concentrate on what they are going to do. But the political milieu, particularly in the US, has changed and has completely kind of created a vacuum. And we are very grateful in terms of the prompt response of the government of Nigeria into coming back to review the plan and quickly rebudget and make sure that some of the significant gaps that were created by the absence of this principal partner were quickly kind of catered for. But again, it is going to see maybe the speed with which we may want to do some of those things may not match some of the earlier things. But again, that's the beauty of having a system that has an early response. And this is one of the fastest times that government has responded in a very rapid manner to a challenge that has come in. And that is the beauty of the SWAP mechanism. Secondly, for this system to work very well, a lot of the Nigerian system from primary healthcare down to the state primary healthcare, both supply and demand, and at the local level to work to the state, federal, is predominantly paper dependent. And honestly, the huge amounts of inputs that are needed to run this smoothly is going to be a big challenge if government and all the other partners don't see how we can, as quickly as we can, move into an electronic model that will allow us to quickly see things and people can correct it at the local level. And this is a challenge that government as well as partners are trying to do the best that they can to see so that they can meet it. I know that particularly the NPHCDA and then the National Health Insurance Agency and the Federal Ministry of and other partners are working hand in hand to make sure that some of the tools that have been created are made into electronic formats, and this training is being done so that this thing can be done so that we can respond not only in terms of policy, but in terms of action down to the patient level at every point in time, and people can use numbers to make decisions because, as it is said, you can only manage what you can count, because if we cannot count it, then it's futile, whatever these things we do. It's also important that particularly the Demographic Health Survey actually came at the right time to give us almost like a baseline at which the implementation of these policies kind of started. And as such, in terms of the next ones that would come, it will be able to give us what I call a scientific proof of how far have we done. Because to improve the quality of care, some of the agreements that have been done in terms of the quality matrices that will be measured have all been imputed that will not only measure processes, because earlier on, most of our matrices have been measuring processes, but now the SWOP is measuring outcomes, so that there's a tool that is going to do that so that we can see not only from a national framework, but also be able to cone on state level, on local government level, almost down to the primary healthcare center and its area of its catchment area, so that it's like we are being much more focused. And together, this coordination that is being done fairly in a very improved manner by the Federal Ministry of Health and the state levels would improve how we do things across the nation for the betterment of our own people.
Super. Dr. Gebi, thank you so much. And you've also attempted or let me say, you've made significant efforts in even answering the next phase of questions I was about to ask you, particularly the efforts of state government to ensuring that SWOP works. You mentioned that the meetings at the instance of the Coordinating Minister of Health and Social Welfare that held in states and different regions is made to bring to bear what the SWOP aims to achieve, and I pretty believe that we would move forward with that effort. Dr. Onyemachi, in the implementation of financial risk protection, we've discovered that some primary healthcare centers have some quantum of inflow of beneficiaries, and some do not have. I give you an example. This primary healthcare center in Kurgui in Plateau State, that we had over 400 people or beneficiaries who are accessing care from that primary healthcare center. And then you go to another primary healthcare center, the volume is very low because of the issues that we had discussed earlier. So how can implementing financial risk and protection mechanisms effectively mitigate catastrophic out-of-pocket expenditures for patients attending primary healthcare centers across Nigeria?
Yeah, thank you so much. Quite frankly, we as a country, especially looking at the economic indices of this country at this time, if we do not take very concrete steps to entrench financial risk protection mechanisms for seeking healthcare, we will actually push a lot of our citizens further into poverty. People will get impoverished, and then we will actually be having a bigger cycle of poverty, infection, and disease happening. It is not lost on anybody, quite frankly, that the only way out, and as a country we have signed up to it, the twin mechanisms, strategies, I beg your pardon, if you may, that we have chosen for ourselves as a country is to say strengthened primary health care and social health insurance as our twin approach towards attainment of universal health coverage, which in any case in itself, most people will define it as a state where everyone has got access to healthcare that is of good quality and all of that. But then I like the definition which the Royal Tropical Institute brought of UHC, that it is when people, wherever they reside, have access to healthcare that is of sufficient quality to be effective. That's the operational word. So wherever people reside, there is ability for them to have sufficient services that will be of sufficient quality to be effective, to deliver especially primary care. So it is important for us to digest that and then begin to work clearly to ensure that across all of our various rural communities where our people reside, that the healthcare, the human resource for health that are in those places are made functional. There must be deliberate attempt to attract and retain human resource for health at those rural areas, such that the confidence of those in those communities, of the residents of those communities, will be built. When we have addressed that supply side issue that border on confidence, that will actually propel the right health-seeking behavior. Because we have studies that show, in Anambra, for example, we did a study on Anambra State Health Insurance Scheme, and it showed us clearly, and that is published in a very high impact journal, that clearly we have 79.1% better health-seeking behavior among individuals who had one form of health insurance or the other, compared with persons who do not have any form of health insurance. We documented this, and then that's the findings of that Anambra study is very comparative with what we got from across the globe. So it tells us clearly that having financial risk protection mechanisms is actually the way to go if we must have very good health outcomes. But then we cannot continue to run the kind of scenario that you painted, whereas in an urban center, for instance, you have all of the full complement of healthcare workers. You have a medical doctor there, or even medical doctors. There are midwives and what have you. There is a functional laboratory. But then you get to the rural areas, these persons do not have such facilities. So you now push them to begin to lose confidence in those facilities there because they must have become slaughterhouses. And if they must seek the formal orthodox health system, then they begin to find themselves ending up in Jos University Teaching Hospital, for instance, coming from those villages. And then we have the tertiary facilities being overburdened with conditions that in some parts of the world, like even in Rwanda, the village health worker is supposed to attend to without even showing up at the primary health center. Nobody treats acute uncomplicated malaria in Rwanda, for instance, in a primary health center. It is done by the village health workers, not even the primary healthcare workers. But then in our own case, we have that up to tertiary health facility level, you are having acute uncomplicated malaria cases showing up there. So how can we change this? The financial risk protection mechanisms, which, for instance, social health insurance affords, there must be deliberate effort to release equity funds that will take care of these vulnerable persons in their various communities. And with those monies, understanding that what comes from the demand side, when you use it in a health insurance mechanism, goes to purchase services through strategic purchasing mechanisms. And that will entail that you are doing provider payment mechanisms to the supply side. So all those supply side primary health centers in rural areas will then have enough lives from those their catchment areas allocated to them as beneficiaries of social health insurance schemes. And at the end of every month, they have the needed resources through payment of capitation from the demand side to provide those services without going through the budget mechanism that we know is quite cumbersome. Sometimes it is on budget, but then the releases is another thing.
This one is fund that is quite ready, that can ensure that there is quality care at that level. And in places where the BHCPF has catalyzed what we do at the primary healthcare level, you see utilization going up. Health center attendance is going up. Skilled bed delivery rates in those facilities are going up. So we really need to ensure that through strategic purchasing mechanisms, practically, we make sure that we cover these rural dwellers. And it is the responsibility of everybody, the federal, the state, and the local governments. We really need to be very deliberate in doing this to ensure that the primary health centers in rural areas and even urban slum centers are well funded. And then this will be reversed. Thank you.
Beautiful, Simeon. Thank you for this insight. Now, you referenced Rwanda, and you and I know that Rwanda does not have a fixed benefit package of health services. And of course, the premiums are different for different cadres. Do you think Nigeria should implement that system going forward towards attaining universal health coverage?
Quite frankly, I want to think that whenever I go to, I always say to folks, let us look at what is working across Africa so that we are not saying what is working in the West and then we have different cultural milieu. In Rwanda, it is very, as I cite it, I am mindful of the fact that they run a unitary government. So it is easy to make a policy and then it just stays. And then for them, they have developed, infusing their culture into their development. They have this Umuganda policy and what have you. But for us, we have so westernized that the basic tenets of our culture is totally lost in the design of our programs. We tend to think more of Western ideas. This World Bank has said this. IMF has said that. This other multilateral organization has said that. So we must take those things without looking at our local context. What can work here? There are solutions. And some of these countries, you talk about Rwanda, they have a system that was largely designed by Nigerians for them. So, but they looked at their cultural milieu and developed what mirrors what their traditional culture and their society will do. And that's why they are able to sincerely say that we have strata. There are the poor people who will not pay anything. There are those in the middle class using the Ubudehe classification, for instance, that will pay 5,000 Rwandese francs. There are those in the well-to-do band that will pay 8,000 francs and what have you. And then the government then takes care for others. They have that clear understanding using the Ubudehe system. But here, we have abandoned the things that worked for us. I always say, and I truly mean it, that the future of Nigeria is in our past. Let us go back to those things that worked in the past and begin to do them, rather than just going full blast for most of these westernized things that researches were done, yes, remotely and what have you, and then these things were done to us. So strictly speaking, we should look at domesticating that Rwandese model at the subnational levels. If at subnational levels, it works because you have just one state governor and then one health system at every state level, then collectively, Nigeria can then have good health outcomes. But to say it will come from top to bottom, like they have done in Rwanda, will not be a plug-and-play solution for us. Thank you.
Thank you, Simeon. You know, at some point in time, we also looked at the options where government gave some people cows, they gave some chickens, and those cows are providing milk, and they sell to the market, and that is also a source of premium. Now, while the federal government has met its own part of the agreement and demands to provide release this funding for the basic healthcare provision fund and all other forms of earmarked taxes, we have had critical challenges associated with states that delay timely and adequate release of this funding. Dr. Gebi, what do you think we should do to tackle this challenge?
Honestly, the experience that we've had and is still ongoing is that the states have been unapologetically the really what I call the slowest part in terms of their own paying for their own components of provision of healthcare across board. In fact, the federal government has been, up till now, the predominant driver of the whole of this strategy. And if I recall, if you look at particularly the SWAP strategy, the framework, there's a huge pillar in terms of state participation. But it's like, with due respect, it's like almost our governors are running states almost as a hegemony of almost self-ownership. And so long as the federal government only gives that 1% consolidated revenue, and it varies. Yeah. It's like the states are the ones that have to take this as a very important thing. And I remember we have had many interactions at the governors forum. We've presented data, government has presented data, but honestly, a lot needs to be done. And again, because of this, what I call the copycat syndrome we have of democracy, the way we are running it, it's like, even if things are budgeted and are passed as law, there's no consequence for state governments or local government not implementing their own parts of a budget that is the law. And therefore, it's that you see a lot of commitment in terms of budgets, but even when they are released, they are completely diverted. If you recall the experience we've had, I'm not sure if it has changed that much in some specific states that have some of the worst RMNCH data in the Northwest, that, when you look at the budget, it's like there was at a point that there's a significant release in terms of resources for health. But when you really look down onto it, it was kind of released to go and solve some huge project that doesn't add any value towards the common man, buildings. Same thing we've had in some states, particularly in the Southeast. And I'm not sure that has changed that much. So until we find a way that we can, in a way, just like we're taking this CRF from the federal government, is it possible for us to bring the stakeholders and let the people take charge to ensure that there's a certain percentage targeting particularly this insurance and support for primary healthcare from the state that is removed from source and kind of comes almost directly independent? Because if people are the power, then they have to drive how this thing gets done. There's just no point we sit down and most of the monies are spent in terms of, looking at the same data. Because if you look at the data we're looking at, it's almost as just slightly better than how it was maybe 5 or 10 years ago. In some places, it's even worse. And until we put these minimal resources, nothing is going to happen, particularly in terms of even supporting the basic human resource that needs to be there. If I recall, something with the basic, what I call wage package that is even given to health workers, that the what do you call it, is that the wage that cannot take you home. And with the inflation and so on, honestly, sometimes we're just being extremely theoretical in terms of hoping that these people that are completely not appropriately commiserated for the work they are doing, we're expecting too much. And like my colleague has also mentioned, it's like there's so much variance in terms of what's available at various local governments and so on in terms of human resource. In many of the places, honestly, you find a lot of redenomination unofficially of hygienists to virtually work as CHUs, and they are doing almost everything that we don't. And that's why, if you look at it, there's a number in terms of the number of health workers that were trained in this almost master training that is less than what government has even hoped to achieve at the local government. In many of the places, they couldn't even meet the basic numbers for CHUs, or talk less of for nurses and midwives. In fact, talking of doctors at the primary healthcare center in many of the places, almost like a dream. And the states need to do much more. And I think we need to devise a mechanism that could empower the people to really have this resource that has been earmarked to be withdrawn almost from source and kind of to go to the PHCs almost directly, because of the benefits that we've seen from the DFF that we're predominantly running from the federal government, part of it to kind of support the vulnerable groups that are targeted in this. Thank you.
Thank you, Dr. Gebi. Simeon, I know you want to add something to this part because you have the data that supports improvement in states that have paid equity funds and then have given some monies for vulnerable groups, and states that have not done that. In less than 2 minutes, can you shed more light on that?
Yeah, quite frankly, it is a potpourri, really. Because where I sit as a privileged chairman elected by my colleagues to help coordinate the state social health insurance scheme. So somehow I have bedside view. And then we have repeated data, quarterly data submission. And that tells us the state of states in terms of health insurance implementation in Nigeria. We have that whereas there are very good progress in majority of our states, I must say, I am very cautiously optimistic as I say this, and also being quite pragmatic, that there is a lot of progress that has been made in the states. But then there are few states where we still have very poor political will, and there's no gainsaying it. That there are states that have done very well. I mean, you have a state like Delta, where, for instance, there is constant release of equity fund to pay for people in hundreds of thousands. You have a state like Lagos, where on a regular basis, they are given equity money. There are releases on monthly basis. In fact, as first line charge to take care of those who are poor and vulnerable in Lagos. You have states like Imo, Katsina, Anambra. There are couples of states across the country, Delta. Some of these states where the law has made it explicitly clear that you must apportion at least a certain percentage or fraction of the state's consolidated revenue to taking care of people who are poor. But then we always, like I will say, have no business doing such. There's a lot of social welfare funds that are untapped in this country. And then lots of inefficiency just go on. I can't understand for the life of me why I will go about distributing, say, 25,000 naira, 50,000 naira to a household because they are poor. Meanwhile, that household, for example, they have a father and a mother who are both aged, have parents who are aged, and then are supposed to benefit from this money. We say we are paying this kind of conditional cash transfers to help them to feed, to take care of themselves. But these people are in the extremes of life who are almost depending on medications. They have lifestyle modifiable diseases, hypertension, diabetes, and all of these kind of things. You give that person, say, 25,000 naira for a household, and then you have two parents who are sick. And when they go to take just for the basic antihypertensives and oral hypoglycemics, that whole money is finished. Why can we not, if we are truly thinking of getting people out of poverty, say, let us put Nigerians on health insurance. When you are poor, let that person be given health insurance so that we are sure that they are not going to spend their money on buying medications, and they will live quality lives. And that household would have been properly taken care of. And there's a clear nexus between a healthy population and a GDP. So if we have that, we put our mouth where our money is to say, let's do the right thing. For every household that is identified, to say we are going to give you these conditional cash transfers that are handed down to us from anywhere in the world, to say, oh, this is the way to get Nigerians out of poverty. Let us take care of their basic needs. Give them access to healthcare. And then the balance of that can then be given to them across board. You see state governments doing this conditional cash transfer things. You see federal government doing it. Meanwhile, those people do not have access to quality healthcare when they need it. And all of the state governments in Nigeria have functional health insurance schemes. The federal government is regulating it at the national health insurance level. Why can we not begin to unlock some of these social welfare funds and channel them to things that are productive? There's no country of the world that has come out of poverty and had got improved GDP indices and what have you through this social welfareism. Not any country in the world. The Marshall Plan that was used for Europe was not distributed as welfareism. So we cannot begin to practice what we are told that this is the way to go. Let us be quite practical and solve these issues practically. When we do all of these spends, then we are going to have our PHCs work, and then the health indices will definitely improve. We'll have good outcomes. Thank you.
Fantastic response. You know, part of what Nextia is currently doing as a multi-consulting firm is to present to Nigerians Frontier Clinics model, where we are bringing quality and affordable healthcare services to people in the peri-urban communities and the rural areas. And I'm sure that in the process, or when we fully implement, Nigerians will see practical solutions because Nigerians actually will pay for healthcare services. Forget the fact that we've always said the informal sector is not synonymous to poverty. There are people who are in the informal sector who have money, but our inability to tax this money or be able to know how much they get constantly is one of the issues why we classify them as informal sector. But of course, where primary healthcare centers give quality services, people will always go to. One reason why people do not go to primary healthcare centers is the fact that they can't guarantee the quality of care that will emanate from there. We're running out of time, but I think in the next two minutes, we should be able to finish. We have a couple of questions to take. And Dr. Gebi, how can development partners more effectively align their financial support with Nigerians' specific primary healthcare requirements?
I think I would want to, because of the things that we are learning, I would honestly want to say that we really need to disabuse our minds about what I call dependence on development partners. Personally, from the lessons that we're seeing, people have actually mentioned it earlier on, but people just don't believe it. With the global, what I call shift towards almost extreme right kind of things, it's like country first, country first, country first. Why don't we put our own country first? And what I mean is that, yes, it's like there are some places where we would definitely need the support of what I call implementing or partners or development partners or whatever they are called. But truly, if we really want to move forward, we have to define what we need and where we want them to come in. Now, this is where, for me, it's like the way I'm looking at it is like in terms of strategic thinking, we need to sit down and really specify almost where we need that support. If you look at it, having been in the development world for some time, it's like almost every development partner has some other strategic reason for pushing health as what I call an entry point.
Sure.
It's not really that health is their main reason. And therefore, you would not expect that your own wishes will be what would be put forward first. And I kind of respect some of the countries that we've seen excellent reforms, particularly in Ethiopia, where the country puts, these are the things that it wants, and we would appreciate if we can receive support to support this agenda that we have for the development of our people. And honestly, if you are the receiver, you have a right to refuse a gift because it may just be a Trojan gift. And until we learn that, and I'm happy that the world is opening now, instead of complaining that, oh, they must, because when every partner comes, they come with, we are going to only help this particular aspect. If you don't want it, honestly, there's nothing you can do. And I feel we must be strong enough to say, look, if this doesn't push our own agenda that we have designed ourselves, honestly, thank you for the gift. You would either re-strategize it to fit our own need, or thank you for the gift. We don't need this gift. I would rather be, with due respect, a dignified, what I call poor person that is sure that the baby is going to live to be an adult and concentrate on making sure that he receives good nutrition, vaccination, treatment of common ailments, than to bother about some things that are important globally, but honestly are not things that we have to do. And until government takes that strong position, honestly, it's like no matter the excellent speeches we're making, we should not, because there's this saying that it said that there's no wrong step, there's no right step in the wrong direction. if they bring that this is the direction they want to go, and we look at it critically and see that that's not our direction, honestly, we should be honored enough to decline it with respect. The tendency that we have of going to sign on to things even before they come into play, I think is something that government may need to look and see, is it really in the long-term strategic interest of Nigerians? Yeah, and I think we should be dealing with strategy so that it's like we have relative advantages of things, and we should be using those things as bargaining tools to almost demand that they should change it, or else we are not really interested. And I recall at a point when in Ethiopia, where a huge development partner was actually denied access, and because we look at the money that is brought as a lot of money. When you compare it with what government and the people of the country put forward, it's actually minuscule, but it's just that it's managed efficiently and effectively so that it looks like it's really big money. Until we stand for that, I'm sorry, it's like we'll just keep on telling the story, because it is not in the interest of the long-term development world for things to work. Because if they work, it means they will drive themselves out of business, because it's a business.
That's revealing, and thank you for speaking truth. Simeon, I can see you smiling. Do you agree with Dr. Gebi? And then, of course, what targeted strategies could boost health insurance enrollment among the currently underserved population in Nigeria?
Thank you so much. I can't agree less. I mean, Dr. Gebi hit it straight, and yeah, this has been quite no holds barred. But having said that, it is to go to your question, you cannot have a government promote a business or a commodity that it does not use itself. For us to have a drive for increased coverage for health insurance in Nigeria, like your question is asking, there is no state government that will establish a state health insurance scheme and has not enrolled its own civil servants into the scheme that will tell me they are serious with their drive for universal health coverage. If you cannot embrace your own products, then there's something wrong with it. So practical steps we must have as a matter of urgency. Every state government in Nigeria having state health insurance scheme cover for their civil servants and their households. Anything short of that means that that state government lacks political will to attain universal health coverage. Because when we do a lot of these spendings, building gigantic structures that are not occupied by any human resource for health workers are not there. There is no targeted plan for health workforce production in our various states, and then we build these gigantic structures. When you go to these countries where things work, for crying out loud, I've been to several African countries where you see facilities that are 80 years old that were built by the colonialists, and those facilities are serving the people. So if we keep wasting resources on these gigantic structures and what have you, neglecting primary health care that should take care of at least 80% of our healthcare needs. If people cannot see healthcare workers in those village settings, they will not embrace whatever you talk about. We must, as a matter of urgency, have civil servants onboarded. You must, as a matter of urgency, have state governments committing themselves to paying equity funds to take care of vulnerable people who cannot take care of, who cannot on their own pay premiums. We must, as a matter of urgency, ensure that we get our people to begin to have reorientation, because you have a system where the healthcare providers who health insurance schemes have paid capitation and fee for service, for example, to take care of the needs of people, who HMOs have paid capitation and fee for service to take care of the needs of people, turn around to deny them services. If they do not tell you that those services are not covered in the health insurance plan, they will tell you that they are waiting for codes, authorization code to come from the health insurance agencies. Meanwhile, those things are not true. For example, in Anambra State Health Insurance Agency, where I am CEO, there is no pre-authorization that does not come to facilities in under 30 minutes because we run a paperless system, like Dr. Gebi alluded to. If you do not have these things digitalized, you cannot track your progress and then make meaningful improvements. We have done it in such a way that everybody who gets to the hospital must be attended to within 30 minutes. But you have healthcare providers who still tell them that they are waiting for pre-authorization codes. Meanwhile, it's untrue. So there is that conscious attempt by some of our healthcare providers to discredit health insurance. And that is for their personal interest that is inimical to the progress of this country. We must then begin to create awareness of the end users to say, you know what? When you go to a healthcare facility with health insurance card, you see the way they are treated. Somebody who has a plan from my scheme, for example, gets to a hospital and the fee-paying patient is attended to. Meanwhile, that insurance patient who came earlier is told to sit down somewhere, and then you're given substandard drugs. Those things, we must begin to call them out. And the patients will then turn around to say, oh, the health insurance has failed. And the popular phrase the young people use, Nigeria has happened to us. Let us form the habit of calling out specific healthcare providers. If I go to a hospital in Anambra with my health insurance card and they do not give me quality services, I shouldn't turn around to say it is Anambra State Health Insurance Agency. I must begin to call out that health facility. We need to begin to have on Twitter facilities being dragged so that they can sit up. Our people must know that the responsibility is a contract. The health insurance schemes have paid them their capitation and fee for service in line with the service level agreements that have been entered into. So why are they not rendering the services? We must begin to stop this Stockholm syndrome. We turn around to blame those who are supposed to protect us. So let us consciously begin to call out healthcare providers, and these things will change. Thank you.
Dr. Simeon, I love the passion, and I know you can talk for the next 5 hours on the question of strengthening the health systems. But there's a question here for you, Simeon, from Ozioma Izuora. He said, as a researcher, if I want to access the state of primary health care in, say, Anambra State today, where will I find information? I ask because I go to home Chrome time to time, but I do not see evidence anywhere.
Yeah, thank you so much. For instance, there is proper, in public health, proper community entry method. Okay, these are public health data. In advanced countries, you see them, you go to CDC website, you can get anything you want. If you go to some of our own websites, they are not updated. So we still depend on the paper-based processes, which Dr. Gebi was talking about, that we cannot make much progress that way. So Ozioma will be frustrated if she's relying on getting secondary data from the system. And that is a failing on our own part as a health system. There's no need sugarcoating it. We must get to a point where you are on government websites and you are able to get data. This is public health data, for crying out loud. So it is wrong, but as of today, if you want to get those kind of data, there is a simple approach. You write to that particular agency, and then you are given the data that you want. But for my own agency, for instance, when you go to our website, I can assure you whatever data you need on Anambra State Health Insurance Scheme is put out there for our people to get access to. And there's nothing to hide for us because that is what it should be. Thank you.
Yeah, I think, sorry, if I may just give some additional information, particularly for the data. I'm aware
I wanted to ask a question that is directed to you. Then you can ask.
That's fine. That's fine.
I know we are not in the academia, so you don't like me referring to you as professor. But this question is from Professor Oladapo Oladipo. He said, what mechanism is put in place to ensure good quality of healthcare services at primary healthcare? And what are the incentives to health workers to ensure retainability in rural PHCs? You could add it to the point that you wanted to make after Simeon concluded his response.
Okay. Thank you very much. Excellent question from Prof. It's our own Prof. So it's we are all beneficiaries from the skills we learned from him. The reality is that at the government level, it's there are a lot of incentives which are being considered at the SWOP secretariat level. But again, some of these incentives are what I call unlikely to be sustainable. The reality is that for me and for most other health workers is that the basic thing that we've told is that so long as even the basic pays that health workers receive at health facilities is just not good enough, there's a limit to what you can expect. Yes, it's like I know that a lot of Nigerians are religious and hoping for better thing on the other side, but I think I would rather live a good quality life here and then at least on the ones I know while waiting for the other end. But honestly, for the best of this thing, there's nothing really on the ground yet. At the state level, some states have advocated some incentives that are limited to the states. Particularly some states, particularly let's say maybe like Delta State, that is kind of receiving some facility from the global funding mechanism that is providing some additionality in terms of incentives for quality of care along the various thematic areas. But this is just limited to Delta State. I'm not sure of Lagos, but it's limited to states. At the federal level, I know that people have talked about maybe people being sponsored to go for some training at the cost of government or some other funder. Again, these have not really been worked very, very well, and as such, are unlikely to be sustainable, or you can say that this is for this particular person. But definitely, for me, if all the primary healthcare facilities are provided with the right tools and the right mechanisms and the right quality checks and supervisions and so on, honestly, a lot of the health workers, and most importantly, they are paid appropriately and on time, most of the health workers would do the best of things that are there. If you look at the framework that has been designed for SWOP, honestly, it looks so beautiful in terms of defining global quality of care on some of the committees that Prof, you are a member of that have defined some of these things. But who will be the ones that will be going to supervise? How are we going to make sure that you have almost a direct mentoring? Because I recall in many of the PHCs that we have had to provide almost direct mentorship, it's like some of them have, last time they can't really remember when any health worker was there. And even on the training facility that government facilitated for the PHCs across all the local governments in Nigeria, many of them, that was the first time they were seeing any form of what I call organized mechanism. And they looked at that as a very serious incentive. And if that could happen in a sustainable manner, honestly, that would really be wonderful. I know that some of the teaching hospitals, the public health departments, in close association with the various departments of pediatrics or ops and gynae for RMNCH, have kind of piloted kind of what I call supervisory mechanisms that will be revolving around a coverage area. Yes, it could work, but again, who will fund it in a sustainable way? So these are things that we have to kind of work together to see what is workable at various levels so that we can all put these things together. One of the things I wanted to contribute to the last issue in terms of the role that development partners can play. Honestly, there's a big issue for me is like development partners could potentially, learning from what has worked in the pension scheme, the self-driven, the self-funded pension schemes. Would it not be possible for government of Nigeria to kind of sign MOUs that if you're bringing resources and you want this money to be kind of ring-fenced so that it is protected to just support primary health care or whatever level of care, so that if that place is covered, can we support that can be invested in a very low risk or no risk funding so that after some certain cycles, we can say that this amount of money is going to be produced almost till infinity, and then it becomes sustainable. For me, if somebody really wants you to grow, for me, that is a mechanism that government should kind of discuss with some of these donors. If you're a donor, you don't necessarily have to go there and involve yourself in the everything. If it is resources you are bringing, this can be done so that it's like it is targeting the primary healthcare to go through that funding, but it starts producing money by its own, so that in about 5 years, the cycle, if you put $1 million in a funding scheme, it's amazing how much money that can produce in a year or two. And after that, if that is going through the fund, it produces a self-sustaining mechanism that you don't need to worry about any other person giving you what I call charity. No one should really be looking out for charity.
Thank you, Dr. Gebi. Simeon, Wanya Emmanuel asked, what's the role of the private sector in financing and revitalizing primary healthcare centers?
Yeah, thank you so much. That's a very vital question, because when we keep talking about primary healthcare, there's a difference between primary health center and primary healthcare. Primary care is sets of services that are defined that can be attended to by a certain level of healthcare worker, as defined by the country in our essential package of care. Okay, so having said that, there is a critical role for private sector to play with regards healthcare delivery system across the places. If I use Anambra, for instance, for our Anambra State Health Insurance Scheme, in our network of healthcare providers, it will surprise you to note that we have more of private providers than the public providers. We have about 180 accredited healthcare providers in the core scheme outside the Basic Healthcare Provision Fund, which is one public primary health center per ward, which gave us 326. But in the core health insurance scheme supply network, we have about 180. And out of this, less than 25% are public healthcare providers. So, and these private healthcare providers in all of those communities in Anambra State are the ones rendering the primary care component of our health insurance scheme. So when people say Anambra State Health Insurance Scheme is working well, part of the success secrets that we have is the fact that there is a push to ensure that there's integration of primary private care providers in what we do. People choose these facilities and they go there to assess a benefit package. So there is that confidence. And in our own minds, what we are thinking is to say, when people in the public sector see that ideally money goes to where people's satisfaction is. So when you realize that you are operating in the same community, for example, with a private facility, and that private facility is having more beneficiaries, more enrollees of Anambra State Health Insurance Scheme in their network compared with yourselves, the public sector, then you begin to tweak things around. So that competition which the private sector brings, the efficiency which the private sector brings, we must leverage on it. And truly, most of the state health insurance schemes are leveraging that so that we do not mix primary care with primary health centers at public levels. Thank you.
Thank you, Simeon. So, Sefia, the primary healthcare centers, as we are now, currently under the supervision of the state primary healthcare boards or agencies with the local governments. And of course, the federal government will be responsible for deploying the 120,000 healthcare workers if the training is done. And of course, the swap approach is what will handle quality and service delivery. These are the questions that we have. I want to appreciate Dr. Simeon Onyemachi and Dr. Usman Gebi, who, despite your other equally busy schedules, for sacrificing your time, your resources, and your energy to join this webinar today. Next year remains eternally grateful to you. But more importantly, we want to appreciate our participants who took their time also to participate in the webinar. This is a thought-provoking discourse, and we are sure that this will shape our policies going forward. I just hope that when next we invite you, you oblige and also continue to contribute from your wealth of experience, how we will strengthen primary healthcare. Thank you, everyone, for being part of this. Until now, until then, goodbye. Thank you so much.